Good morning, everyone. At the outset, I would like to thank the organizing committee for giving me this opportunity. The topic given to me is assessment of filling pressures by echocardiography. The term filling pressures, the problem with it is actually it is very ambiguous in nature because it is open to interpretations like it can denote either LVEDP or a mean inlay pressure or pulmonary capillary wedge pressure and so on. Maybe in a normal heart, all these pressures are normal, equal, almost equal at the end diastole. But when there is a cardiac pathology, there are some discrepancies between all these pressures. Now look at this pressure tracing of two different patients. Both patients have a LVEDP of around 30 millimeters of mercury. But look at the LA trace, the orange line. In patient 2, it is very much increased, and in patient 1, yes, it is almost low. So why is this happening? When the LV-EDP is increased, the initial response is compensated by the LA contraction. It tries to push in the volume so that the LV-EDP filling is elevated up to the level of LV-EDP, and it also permits the mean LA pressure to remain low. So this goes to say that though we use similar parameters for classification of diastolic dysfunction and assessment of LA pressures, both have different implications. LA pressure can be normal even in cases of mildly elevated LV-EDPs. So the next few slides will be based on this recommendation published in 2016 regarding the assessment of LA filling pressures. These recommendations are not applicable in the perioperative period and in the children. It is always a good practice to do a preliminary cardiac examination to assess the LV dimensions, the systolic function, and also know the diastolic dysfunction before going into assess the LA pressures. So the first step in assessing whether the mean LA pressure is increased or not is looking at the transmitral Doppler gradients, the pulse Doppler gradients, the E velocity and the A velocity. E velocity is the early transmitral inflow gradient, and the A velocity is the late transmitral velocity gradient. When E by A velocity is less than 0.8 or E velocity is less than 50 centimeters per second, we say the LA pressures are normal. At the other end, when the EA velocity is more than 2, that means all of the filling of the LA has happened by the early diastolic period itself, and the late diastolic filling is very low. We say it is in type 3 diastolic dysfunction. Now, what happens when it falls in somewhere a value between 0.8 and 2, and the EA velocity is more than 50 centimeters per second? So we start looking at three different criteria. One is the ratio of E by E prime. What is E prime? E prime is a myocardial velocity measured at the mitral annular level. It can be measured at septal or lateral annulus. Here it is the average E by E prime, which is calculated by measuring the E by E prime at the septal and the lateral level and finding an average. Second thing is look at the TR velocity. So we are going to assess whether there is any signs of post-capillary pulmonary hypertension. And third thing, you look at the LA volume index. LA volume says that the LA pressure is increased and is long-standing, and the LA has undergone the remodeling changes, and it has dilated and lost its compliance. So when two of these things are positive, we say the LA pressure is increased. When two of these things are negative, we say the LA pressure is normal. Now, what happens when you have only measuring two values and one is positive and one is negative, or we are getting only one value? We say LA pressure cannot be determined, or these fall in the indeterminate ranges. Is there anything else that can help that may be helpful in such indeterminate cases? Yes, we can use pulmonary vein pulse wave Doppler in such cases. This is how a normal pulmonary vein pulse wave Doppler looks. It has two positive waves, systolic wave S wave and the diastolic wave. The S wave is actually a flow of blood into the left atrium during the ventricular systole. It has two components, S1 and S2. S1 is determined by the LA relaxation, and S2 is determined by the RV stroke volume and LA compliance. What is D velocity? D velocity is flow of blood from the pulmonary vein into the LV through the LA. It is a diastolic filling happening. So this reflects on the LV compliance. And third wave is the A wave or the atrial reversal velocity, which is determined by the LA contraction. Now, this is how all the waves are related. The pulmonary vein S wave is related to the X descent, and D wave is related to the Y descent of the LA pressure trace. And the A wave is related to the A wave in the atrial trace. Similarly, the D wave closely follows the E wave, the early transmitral diastolic gradient. And the atrial reversal velocity uh, is seen during the A wave filling velocity in the mitral pulse wave Doppler. Now, what happens when there is an diastolic dysfunction? Sorry, when there is an LA pressure is increased. The LA pressure, when it is increased, the LA has undergone remodeling and the LA compliance is decreased. The flow into the LA during the ventricular systole is decreased, and so the S wave is decreasing in amplitude. What happens? The compensation happens when all the volume starts flowing during the D diastolic period. That is, the D wave starts to increase. So there is in the early stages there may be S blunting, and later on S velocity is less than D. So when S by D is less than 1, we say the LA pressure is increased. Otherwise, we can find another value called the systolic filling fraction, where we trace the VT of the S and D wave, and the VT of the S wave divided by total VTA, we use the systolic flow fraction. When it is less than 40%, we say the LA pressure is increased. One more thing to be mentioned here is the atrial reversal velocity. Say in case of advanced LV dysfunction, almost all the filling happens in the early transmitral diastolic period. Now, what happens? The LA contraction, actually LA tries very hard to push more volume into the LV. So it contracts with a higher velocity for longer duration. But LV is already full. It is not ready to take any more volume. So all these things reflected back into the pulmonary vein trace. You get a higher velocity and for a longer duration. So atrial reversal velocity more than 35 centimeter per second, and the difference between the atrial velocity, reversal velocity duration, and the atrial velocity duration more than 30 seconds, say the atrial pressures are increased. One more thing coming up recently is the LA strain pattern. So in case of indeterminate patients where LA pressure cannot be determined, even when assessing for a pulmonary vein pulse wave Doppler, we can look at the LA strain. There are three strains of LA. LA has three functions: the reservoir function, the conduit function, and the contractile function. Similarly, there is a reservoir strain, contractile strain, and a conduit strain. Normal strain is more than 35%. When the LA strain is less than 35%, you can say the LA pressure is increased. So in cases of indeterminate or where LA pressure cannot be measured by the traditional parameters, you can go for LA strain to differentiate between normal and indeterminate, normal and high LA pressure patients. So what happens in case of patients with valvular heart disease? In mitral valvular lesions like MS or MR, the E by A velocity becomes invalid in severe cases. So what findings we can use? Like in stenosis, we can use isovolumetric relaxation time as a ratio of IVRT to time difference, the difference between the E velocity and the E prime velocity. Similarly, in mitral regurgitation, we go by similar by the isovolumetric relaxation time and the ratio of IVRT to TE minus E prime. In AS and ER, you can go with the regular flowchart that was mentioned previously, but you should be careful about the mitral annular calcification in case of calcific AS, because when the annulus is calcified, your E prime excursion is decreased. Apart from this, in aortic regurgitation, premature closure of the mitral valve or diastolic MR or abrupt cessation of the diastolic filling will tell you that LA pressures are increased. Now, in patients with atrial fibrillation, particularly in impaired ejection fraction, you can measure the isovolumetric relaxation time or ratio of E velocity to the propagation velocity VP. When it is more than 1.4, you can say that the LA pressures are increased. Now, what happens to the RV filling pressures? As in LV filling, there are no formal guidelines which guides you for assessment of RA filling pressure. So we try to measure what we measure in the LV side, and from that we are trying to extrapolate how we measure increase in LA pressure. We are trying to measure the RA pressures. So these are the values that are measured, which include the RA dimension, the RV volume, the ED by A ratio, E prime, and all these things. These are the normal values. When the RA area is more than 11 centimeters per meter square, or the E by prime A tricuspid valve E by A ratio is more than 2.1, or the RV E by E prime more than 6. All these things tell you that the mean arterial right atrial pressure or the RV filling pressures are increased. When there are similarly, when severe TR and all those stuff, we can go with the isovolumetric isovolumetric relaxation time of the RV, which less than 50 milliseconds or 59 milliseconds tell you that the RV filling pressure are increased. Similar to pulmonary vein pulse rate Doppler, we have the hepatic vein pulse rate Doppler on the right side. So when the S by D, similarly, we have two forward waves and one negative wave, S wave and the D wave, and atrial reversal wave. There is one more negative wave, the V wave, which is seen between the S and D waves. Usually this is very minimal and it is not usually seen. When the RV filling pressures are increased, you get a prominent V wave velocity. Apart from this, as told in the pulmonary vein pulse rate Doppler, S by D ratio less than 1 and the hepatic vein systolic filling fraction less than 50% tells you that the RV filling pressures are increased. Now, based on the IVC assessment, you can come to a conclusion of whether RA pressure is low, high, or normal. When the IVC diameter is less than 2.1 centimeters and it is more than 50% collapsible, you can say the RA pressures are low. On the other hand, when the IVC diameter is more than 2.1 centimeters and is less collapsible, we can say that the RA pressures are high. And whenever there is always a in-between patterns. Now, this method is only valid in spontaneously breathing patterns 1, and it can tell you whether it is high, low, or normal. It does not give you a precise numeric value. So what happens when a patient is in mechanical ventilation or the intraoperative period? We have two indexes. In IVC, we have the distensibility index, and in SVC, we have the collapsibility index. Distensibility index more than 18% or collapsibility index more than 36%. Both of these tell you that patient will respond to your volume loading. That means the filling pressures are low. They do not differentiate normal and high filling pressures. They can only tell you it is low. Now, what are some equations where you can use to calculate the filling pressures? That is the pressures inside the chambers. For this, you need invasive lines, the invasive arterial line or pulmonary artery culture. You know the actual pressures. You need some kind of regurgitation happening, like MR or pulmonary regurgitation or tricuspid regurgitation. And echo-wise, your Doppler angle should be parallel to the flows, at least within 20 degree, within a maximum within a 20-degree error. And all your tracing should be accurate and complete. This is the most common equation which is measured by everyone. The right ventricular systolic pressure, which is equal to 4 times the TR peak velocity jet velocity square plus RAP. So similarly, left ventricular systolic pressure would be 4 times the MR peak velocity square plus LAP. So when you rearrange this, you'll get the left atrial pressure. It is left ventricular systolic pressure minus 4 times the peak MR jet velocity square. So now PA diastolic pressure will be 4 times the PR end diastolic velocity square plus RV EDP or right atrial pressure. Similarly, aortic diastolic pressure will be 4 times the AR end diastolic jet velocity square plus LV EDP. So when you rearrange, you will get the LV end diastolic pressure, that is aortic diastolic pressure minus 4 times the AR end diastolic jet velocity square. So what is end diastolic velocity and peak diastolic velocity? When you get the regurgitation trace, the highest point is the peak diastolic jet velocity and lowest point at the end of the regurgitation is the end diastolic jet velocity. These are some of the other formulas which by which you can calculate the waist pressure or right atrial pressure or the CVP from IVC diameters. Thank you. Like, assessment of LV filling pressures is just 10% of your job done. So rest 90% is what you do of the LV pressures, because the LV pressures actually tell you what is the volume management of this patient. So when you have the background data of LV pressure, whether it increase or decrease, you can actually use your filling status or volume status to optimal management, fluid management of the patient. Thank you.